Welcome to the Deep Dive, where we really try to unpack complex topics and uncover some surprising insights for curious minds like yours. Today, we're plunging into a pretty fascinating medical question. It's right at the intersection of, everyday medicine and really complex patient care. We're going to tackle a critical debate. When is a common, really inexpensive pill like aspirin actually a good choice for preventing dangerous blood clots after orthopedic surgery, especially things like bone fractures? We've got quite a stack of research here, including some major recent trials that, well, they caused quite a stir in the medical community. We'll dig into the data, the nuances, and what it all really means for individual patients and their doctors making these calls.
Yeah, it's a classic example, really, of how scientific findings, even from these big, well-designed trials, they often need really careful interpretation for, real-world use. We need to look beyond just the headlines to understand the evidence both for and against aspirin, especially when you compare it to other standard treatments. We're talking about preventing venous thromboembolism, or VPE. And just as a quick refresher for everyone, VTE covers deep vein thrombosis, that's DVT, where a clot forms in a deep vein, usually the leg, and pulmonary embolism, or PE, which is the dangerous part, where a piece of that clot breaks off and goes to the lungs.
Okay, so let's dive right in. Why is this such a vital area of research? What makes it so important?
Well, first off, the sheer number of people affected. Major orthopedic surgery like hip or knee replacements or fixing a broken arm or leg, it just significantly ramps up a patient's risk of developing VTE. And we often talk about different types of DVT. There are distal ones further down the limb, but the real worry, and often the focus of prevention, are those proximal DVTs, the ones closer to the body's core. They carry a much higher risk of breaking off and causing that potentially fatal pulmonary embolism.
Right. So why orthopedic patients specifically? Is there something about bones and joints that makes them, I don't know, a perfect storm for these clots? What's actually happening inside the body?
It often comes down to something called Virchow's triad. It's basically three main things that kind of conspire to form clots. First, there's venous stasis.
Yeah.
Think sluggish blood flow. This happens a lot from immobility after surgery or an injury, being stuck in bed, maybe paralysis. Even things like obesity can play a role here.
Okay, slow flow. What else?
Second is vascular damage. The surgery itself or the trauma from the fracture can directly injure the blood vessels. And that creates a rough spot where clots can easily start forming.
Makes sense. Damage invites trouble.
And the third part is a hypercoagulable state. This just means the body becomes more prone to clotting than usual. It can be triggered by the trauma itself or certain underlying conditions like cancer, specific genetic issues, or even some medications like drugs containing estrogen.
So beyond the injury or the surgery itself, are there specific things about the patient that put them at higher risk?
Oh, absolutely. Key risk factors definitely include being age 40 or older, having a higher BMI, especially over 30, that's considered obese. Also, a personal history of having a VTE before, actively having cancer, or even things tied to the procedure itself, like really extensive surgery, being under general anesthesia for a long time, or specific fractures like the hip, pelvis, or the long bones in the legs.
Wow, okay. So given all those risks, it's no wonder that preventing clots with medication thromboprophylaxis, you called it, is standard practice. But you hear that patients often really lean towards aspirin. Why is that the case?
Yeah, and it's a very understandable preference. It mostly comes down to two things. Lower cost, and it's just easier to take. Aspirin's an oral pill, right? That's much more appealing to most people than, say, low molecular weight heparin, LMWH, like enoxaparin, which needs daily injections.
Ouch. Yeah, I can see that.
So that convenience and the cost factor often make patients, and sometimes doctors, really hope aspirin is a good enough option.
Okay, so for years, LMWH, the injections, were kind of the standard, the go-to. But with patients wanting aspirin, these recent big trials have really put it under the microscope. Let's maybe start digging into some of the most influential ones. How about we begin with a study focused on joint replacements? EPC2, I think it was.
Yes, EPCAT-2. That was run out of Canada. A large, double-blinded, randomized study. So good quality design. It compared giving extended prophylaxis, that's prevention treatment, after the initial period, using low-dose aspirin versus rivaroxaban, which is another type of anticoagulant pill. This was specifically in patients having elective total hip or knee replacements, THA and TKA.
And what was the big takeaway?
The key finding was that aspirin was non-inferior to rivaroxaban for preventing symptomatic VTEs. And importantly, both had similar rates of bleeding complications. So on the surface, this sounded really promising for aspirin's role.
Okay, that word non-inferior keeps popping up. Can you maybe unpack that a bit more for us? Because not worse doesn't automatically sound like just as good, right?
That's a really crucial distinction, you're right. When a drug is declared non-inferior, it basically means it was statistically shown not to be worse than the comparison drug, but only within a specific, predefined, acceptable margin. Doesn't strictly mean it's better or even exactly equal in every way, but its performance falls within a range that's considered clinically acceptable or close enough.
Ah, okay.
And for a common, super inexpensive drug like aspirin, just showing it's not significantly worse than a newer, much more expensive alternative like rivaroxaban, well, that can be a pretty powerful finding in itself.
Got it. So EPCAT2 gave us this hopeful result, but in clinical trials, the devil's often in the details. Were there any specific things about its design, any caveats we should know?
Yeah, there were definitely some important details to consider. For instance, in that trial, patients actually got rivaroxaban for the first 5 days after surgery before they switched over to aspirin. Now, that's not always how aspirin is used in practice if it's the main agent from the start.
Right.
Also, this study mainly looked at a patient group that already had a pretty low baseline risk of VTE, and it specifically excluded distal DVTs, those lower leg clots, from its main outcome measure. Although, to be fair, those didn't happen very often in the trial anyway.
Okay. So those design choices definitely affect how widely you can apply the results.
Exactly. It limits the generalizability somewhat.
Okay, so if EPCAT2 offered that hopeful glimpse, the next big study you mentioned, the Crystal trial, kind of threw a wrench in the works, made people pause. This one also looked at hip and knee replacements, but compared aspirin directly against LMWH, right?
That's right. The Crystal trial. This was an open-label, cluster-randomized study. Its goal was to see if aspirin alone, started right away, was non-inferior to enoxaparin, that's a common LMWH, for preventing symptomatic VTE within 90 days. So unlike EPCAT2, aspirin was given within 24 hours after surgery.
And open label means?
Open label means both the patients and the researchers knew who was getting which treatment. There was no blinding.
Ah.
Which, is a potential limitation because it can sometimes introduce bias in reporting or assessing outcomes.
Okay, so what were the results there? Did aspirin hold up?
Well, this is where it gets really interesting. In Crystal, aspirin actually led to higher rates of symptomatic VTE compared to the enoxaparin group.
Higher? Wow.
Yeah. And this difference was mainly driven by an increase in those distal deep vein thromboses, the ones lower down in the leg.
So aspirin actually did worse in this head-to-head comparison. That's a pretty stark contrast, EPCAT2. It really changes the story a bit.
It absolutely does.
Right.
Now, Crystal had its own limitations, like we mentioned, the open-label design. And there were some differences in how LMWH is typically dosed in the U.S. versus how it was used in the trial. Plus, again, like EPCAT2, it involved a patient group that overall had a fairly low baseline risk for VTE.
Okay, this is getting complicated. So now let's bring in the main event for our deep dive today, the PREVENT CLOT trial. This one, you said, focused specifically on patients with extremity fractures, like arms and legs or hip fractures. That's a different crowd than the joint replacement folks in the other two trials.
Exactly. The PREVENT CLOT trial was huge. An open-label, randomized controlled trial across 21 trauma centers in North America, over 12,000 adult patients. These were patients with limb fractures needing surgery or fractures of the pelvis or hip socket. And they directly compared low-dose aspirin 81 milligrams twice a day to a standard dose of enoxaparin 30 milligrams twice a day.
Okay, the big question. What did they find? Was aspirin as good as LMWH in this group? Especially keeping that non-inferiority idea in mind.
So the primary outcome they looked at was all-cause mortality death from any reason at 90 days. And on that specific measure, aspirin was indeed found to be non-inferior to LMWH.
Non-inferior for death rate, okay.
Yeah, the actual death rates were very low and very similar, about 0.78% in the aspirin group versus 0.73% in the LMWH group. Clinically, that difference is tiny, basically negligible. So for preventing death within 90 days in this population, aspirin held its own against LMWH.
That is a really critical finding, especially regarding mortality. But hang on, if aspirin was non-inferior for death, how does that square with the other trials like Crystal showing more clots? Did PREVENT CLOT look at clots too? It feels like there's a piece missing.
That's a fantastic question, and you've hit on exactly where the nuance comes in. Yes, they absolutely looked at clots as secondary outcomes. And while mortality was similar, when they looked specifically at deep vein thrombosis, LMWH was actually superior to aspirin.
Superior, meaning fewer clots with LMWH.
Exactly. Symptomatic DVT happened in 2.51% of the patients getting aspirin, compared to only 1.71% of those getting LMWH. So aspirin was associated with significantly more DVT events in this trial. And again, this difference was largely driven by an increase in distal DVTs, the ones on the lower leg.
Okay, more distal DV2s again.
But here's a really important piece of the puzzle. While there were more DVTs with aspirin, there was no significant difference between the groups when it came to non-fatal pulmonary embolism, the more dangerous clots traveling to the lungs.
Ah,
And also, importantly, there were no significant differences in bleeding complications, wound issues, or infections between the aspirin and LMWH groups.
okay, let me try and recap that because it's crucial. Prevent Clot found aspirin wasn't worse for overall survival and wasn't worse for causing dangerous PEs or bleeding. But it did lead to more of those less dangerous distal DVTs compared to LMWH, is that right?
You've got it perfectly. More distal DVTs, but similar rates of death, PE, and bleeding.
So if that's the trade-off, maybe more minor clots, but no difference in major ones or death, plus it's cheaper and easier, why is this trial still debated? Why isn't it just a clear win for aspirin in this group?
Well, this brings us back to that really critical point about generalizability, about who was actually in this study. The influence and the debate around PREVENT CLOT hinge heavily on the patient population they studied. Remember, this trial primarily included younger patients. The average age was only about 40, 45 years old,
Younger, okay.
and most of them had what's considered non-major trauma.
Meaning they likely had a relatively low risk of VTE to begin with. Are you suggesting these results might not apply to, say, older, sicker patients?
Precisely. That's the heart of the discussion. For example, in this huge trial, only 0.7%, less than 1%, had a prior history of VTE. Only 2.5% had active cancer. This is a very, very different profile compared to, say, your typical hip fracture patient who is often over 70, maybe has heart disease, other issues, a much higher baseline risk.
Right.
The trial also included patients with upper extremity fractures, arm fractures, and for many of those, thromboprophylaxis isn't even standard practice, according to many guidelines.
So including them might dilute the results for higher risk leg fractures.
It potentially could, yes. All this significantly limits how broadly you can apply these findings. What seems like an acceptable trade-off for a relatively healthy 40-year-old with a broken wrist might look very different for an 80-year-old with a complex hip fracture and multiple health problems.
That makes a lot of sense. You really have to consider the individual. Were there any other limitations that people pointed out when critically looking at Prevent Clot? You mentioned raising a flag earlier.
Yeah, some appraisals noted a lack of really detailed information on the specific locations of the lower extremity fractures, because where the break is can influence risk. Also, more detail on the exact types of surgeries performed would have been helpful. Another point was about adherence. While they tracked if patients took the meds in the hospital, compliance after discharge wasn't really elaborated on, and that could definitely affect the outcomes, especially over 90 days.
Right, if people stop taking their meds.
Exactly. And regarding that flag, the primary outcome. Originally, the trial might have focused more narrowly on PE-related death, but it shifted to all-cause mortality. While this change was apparently done blinded to the results, anytime a primary outcome shifts during a trial, it's something researchers look at closely during appraisal. Not necessarily wrong, but noted.
Okay, so we've walked through these key trials, EPCAT-2, Crystal, Prevent Clot, each with different designs, different patient groups, sometimes conflicting results, and always those important limitations. This paints a really complex picture. It's not just numbers on a page. This directly impacts real people recovering from major injuries or surgeries. So, given all this complexity, how do doctors actually navigate this? If aspirin is cheaper, easier, but maybe means more clots in some cases, how do they make that call for an individual patient sitting in front of them?
Yeah, that's the million-dollar question, isn't it? And this is exactly where clinical practice guidelines come into play. But, and this is a big but, the guidelines themselves aren't always perfectly aligned, and they absolutely must be used together with solid clinical judgment. It's about tailoring it to the specific person.
So what do some of the major guidelines actually say?
Well, if you look back at the 2012 chest guidelines, these were influential guidelines from the American College of Chest Physicians. For total hip or knee replacement, they generally preferred LMWH over aspirin. For hip fracture surgery, they also leaned towards LMWH. They specifically noted back then that much of the evidence supporting aspirin was older and used less reliable methods for detecting DVTs.
Interesting.
There was even one panel member on those guidelines who felt very strongly that aspirin alone just shouldn't even be listed as an option.
Wow, strong opinion. But guidelines evolve, right? What about more recent ones?
Exactly. Things change as new evidence comes out.
Huh.
If you look at the American Society of Hematology's 2019 guidelines, you see a bit of an evolution. They actually suggest that either aspirin or anticoagulants like LMWH or the newer pills can be used for VTE prevention after joint replacement. If anticoagulants are chosen, they tend to favor the newer direct-acting oral anticoagulants, the DOACs over LMWH, and LMWH over older options like warfarin or unfractionated heparin.
So, newer guidelines seem a bit more open to aspirin, but it's still not a simple yes or no. It sounds like there's a recognized place for it, but it's definitely not a universal fix. It's still that balancing act.
It absolutely is a constant balancing act in medicine. You said it perfectly. Ultimately, the choice of which thromboprophylaxis to use, it has to be highly individualized. It really hinges on a careful, sometimes quite nuanced assessment of that specific patient's risk factors for getting a clot versus their risk factors for bleeding if they take an anticoagulant.
Can you give us maybe a few concrete examples of how that might play out?
Sure. Let's try to simplify based on some common scenarios. So always remember, individual judgment is key. So say you have a patient getting a unilateral, just one side total hip or knee replacement, and they have no other major VTE risk factors. For that patient, aspirin, maybe 81 milligrams once a day, might be considered a reasonable option, perhaps after an initial short course, like 5 days of LMWH, or a DOAC right after surgery, like an EPCAT2.
Okay, lower risk, maybe aspirin is okay. What about higher risk?
Right. But now take someone getting that same surgery, but they have one or more factors that enhance their VTE risk. Things like a BMI over 35, a history of previous VTE, active cancer, maybe significant kidney problems. For that patient, LMWH or one of the DOACs is generally the recommended approach.
Makes sense. Stronger protection for higher risk.
And if someone is having bilateral surgery like both knees replaced at the same time, that's inherently higher risk, so LMWH or a DOAC is pretty consistently recommended there.
Okay, what about the fracture patients, like in PREVENT CLOT?
For extremity fracture repair, the thinking might be something like this. If the patient comes in quickly, say within 48 hours of the injury, and they don't have additional VTE risk factors, similar to the PREVENT CLOT population, then aspirin, maybe 81 milligram twice daily as used in the trial, could be an option. But if that fracture patient does have risk factors like a BMI of 30 or more, a previous clot, active cancer, or a really severe overall injury score, then LMWH or maybe unfractionated heparin would likely be preferred over aspirin.
This really highlights just how complex it gets and how critical that personalized assessment is. It's definitely not as simple as just saying aspirin worked or aspirin doesn't work. It depends so much on who the patient is, what kind of injury or surgery they had, and their whole health picture.
Exactly right. It's all about context. And the science is definitely still evolving. There are more trials ongoing right now, like PEPPER and EPCAT3. They're continuing to investigate these questions, comparing aspirin to other drugs for different orthopedic situations and looking at different outcomes. So the recommendations might continue to be refined as we learn more. It's a field that's actively being studied.
So we've taken a really deep dive today into aspirin's very nuanced role in preventing blood clots after orthopedic trauma and surgery. Thinking back over our whole conversation, what stands out to you as maybe the most surprising or impactful takeaway?
For me, the real aha moment isn't just that the guidelines vary, but how dramatically the patient's characteristics, things like their age, their weight, their other illnesses, even the type of fracture can completely change the calculation. It changes whether a common cheap pill like aspirin is genuinely the best, or even a safe choice. We saw how sometimes, counterintuitively, it might lead to more clots, even if not the most deadly kind. It really drives home that we have to look beyond just those headline claims of non-inferiority for something like mortality. Because not worse for death doesn't always mean just as good for all the important outcomes, especially when it comes to preventing those DVTs.
That's a really powerful reminder. Even with medications we think of as simple or everyday, the reality of making medical decisions is incredibly complex, it's nuanced, and it's always shifting based on the latest evidence. And that, my friends, is exactly why we take these deep dives. Until next time, keep asking those hard questions, dig deeper, and stay curious.